Most AI in healthcare fails before it ever even reaches a patient. Not because the technology can't do the job, but because nobody really translated it into something a clinician could actually use. Dr. Sanjay Juneja has spent his career closing exactly that gap. He's an oncologist who sees patients. He's also building and shipping real AI into clinical workflows. And he's an author and an influencer who has a massive global following by making all this hard stuff really easy to understand. And today, he's here to do the exact same stuff for us. Now, welcome back to Humanify Health Tech, where we explore how AI is really rewriting the rules of healthcare and putting people right back at the center where they belong. I'm your host, Francesca Vereb, Head of Marketing at NetHealth. Today's guest has a gift for that genuinely rare talent in this industry. He can take something that is impossibly complex, like a cancer diagnosis, an AI governance framework, or even a broken data pipeline, and make it practical to the people who need it the most, which, as a marketer, frankly confuses me to some extent, but also impresses me in equal measure. Dr. Sanjay Juneja is a triple board certified hematologist and medical oncologist. He's the VP of Clinical AI Operations at Tempus AI and the founder of Tensor Black, an AI education platform that's really focused on oncology. He's also known as the OncDoc on social media. Dr. Juneja has built a global following of more than 500,000 people, and his podcast, Target Cancer, has been downloaded over 4 million times. He's written on Forbes, he's been credentialized through Harvard Medical School's inaugural AI healthcare program, and he was invited to the White House for a roundtable on healthcare leaders in social media. And somehow, in between all of that, he still has a couple of hours to see his patients. Dr. Juneja, welcome to the Humanify AI Health Tech podcast. So, Dr. Juneja, you've built your career around one skill, taking topics in healthcare that are genuinely really complicated and then making them much more human. And you do this with patients and you do it with your social media followers, and you do it in one of the most complex AI deployments in oncology. So what I would love to know from you is, what is the one sort of moment from the bedside that just sort of shapes how you think about AI, something that happens organically in the room with the patient? And what does that tell us about the gap between what AI builders are thinking about and thinking that clinicians need and what clinicians actually need?
Yeah, it's a great question. I think really the most important thing that made me realize we have kind of a technology, insufficiency is really just the quote unquote ball drops that happen when it relates to just a very important thing as it relates to the patient's care. So obviously with cancer treatments, there are all kinds of side effects that can happen, especially with immune therapy and other things that can be a little nebulous. So you have to have a really interdisciplinary, collaborative approach, right? Meaning like I got to send my patient to the GI oncologist or to the endocrinologist because of a pancreatic insufficiency, either to do the therapy or because of the Whipple's procedure or whatever they had for their cancer. But the problem is a lot of times you'll have somebody admitted or in clinic, and you don't have the report of the endoscopy that was done, or you don't have the findings of the cystoscopy for their bladder cancer and where did it originate. And these little delays add up over time, and it can be very problematic, unfortunate. It causes moral injury, on behalf of the physician and their team. And that's where I first kind of saw this excitement or hope, which was, at the very least, we've got to use natural language processing and the ability that LLMs, frontier models provide us to be able to query things that otherwise we're just running around chaotically and saying, can you get a hold of so-and-so and get that faxed over? And I need that right now because they drove an hour away because I'm in a community setting. I mean, these kind of problems are just all the time, every day. And when they lead to medical error, that's really unfortunate, just because technologically, if you could snap your fingers and red tape wasn't an issue, that shouldn't be happening. So that's kind of what started this whole idea.
Right. So we're going to come back to LLMs because I love that thread. But let's just pause for a second because you've done a ton of things in your career, and you've also got a startup, and you work across a number of different spectrums. But you've really watched AI go from this like headline at a conference, right, to really seeing what gets demoed and what actually gets deployed. And in our field at Net Health, the clinicians that we serve, rehab therapists, wound care nurses, the occupational health specialists, they're all asking the same question. And if we're really honest, many of them lived through this whole notion of, hey, an EHR is going to deliver all these amazing things. And it didn't really. So what really separates AI implementations from actually work to those that actually get abandoned? And what's the question that clinicians should be asking vendors that most of them are not doing right now?
Oof, that's a good question. The Arise Collaborative, which is a collaboration between Harvard and Stanford, has a great status of clinical AI report. And they mentioned exactly what you said, how there's just a lot of hype on what can be done, but then what actually was done in 2025 and early 2026. And it seems like the adoption so far has been kind of on some lower hanging fruit things. Obviously, I think the biggest quote unquote success story so far is this ambient listening ability, which, isn't just a transcription of a recording. It's an actual process that happens behind, at least depending on the ambient company, in the background that can actually take this kind of clinical context and potentially use what's called a RAG system to be able to look at guidelines and make sure or even parts or features of a chart and pull it up as it's pertinent as you're transcribing these notes. So there is that element of it that is pretty widely adopted. And then some other low-hanging fruit places are prior authorizations, this thought that, okay, if we have diagnoses, we have CPT codes, we have, something listed somewhere on what qualifies this person to be able to get this either treatment or, workup or study, et cetera, then can we build like an agentic system that's able to put these into something tighter so that we don't have these delays in care, like I mentioned previously. So these areas are of interest. They require natural language processing, as mentioned. They require, understanding of clinical context. But then if you take it to the next level that I think people are anxious or eager to get to that isn't, here quite yet, a big one for me is referrals and the ability to look and tell when something is appropriate or necessary and help coordinate or facilitate that referral. So whether it's, what's called neoadjuvant therapy, meaning like the surgeon should be cued to say, hey, you might want to send this to a medical oncologist because the data showed 6 months ago that getting treatment before a curative surgery actually improves survival. Like there's that level of referral referring nature. But then also when it comes to wound care, as you said, or if I'm talking and dictating or at least saying out loud, hey, you're having trouble, getting up from the bed and going to the bathroom, and I'm going to talk to social work and to a rehab center to see if you qualify for outpatient rehab versus inpatient. If I'm saying all of this, then it should be able to assess, oh, well, that's a functional deficit because they need to be able to get up and can't without assistance to go to the bathroom. That qualifies for XYZ. So I'm going to send it for this level of intensity when it comes to rehab. These are all technically possible. I don't know that they're, fluidly in the field yet, in part due to interoperability issues, because sometimes these facilities work on a different system than the one that you're, saying all this out loud in the clinic. So there's all these kind of technical barriers, but that's where people get excited because you could just imagine how much tighter and more accurately things are happening across the board, because I know what I need to do, right? The therapist knows what qualifies for. The patient's telling you exactly what is, and you're probing that. Why can't there be an agentic workflow that can then make sure all of those things are coordinated rather than now me shooting off a text to this or somebody getting me out of a room, et cetera, et cetera?
Yeah, it's such an interesting point because I think a lot of what you're also saying here is so dependent on this data, right, that underpins absolutely everything. And one of the articles or the pieces that you had written for Forbes, this AI healthcare paradox, I believe is the name of the article, you really made the case for the fact that AI is only as trustworthy as the data that's behind it. And that the challenge here is that you've got health systems, like in the examples that you just described, that are really training models, but it's only on their patient populations that they have in their particular remit, right, or their field, their scope. And so when we think about that, is this really sort of a data quality argument in principle? You also mentioned interoperability, right? And so when you actually start to look at that, is the foundation wrong, right? From a clinical setting? And what does this full picture demand from, say, a specialty EHR in our case to fix that whole paradox?
Yeah, it's challenging because, the mind doesn't know what the eyes haven't seen. So as these things have been propped up to be able to catalog data, it wasn't with the thought, I don't believe, that, hey, one day we need to, tokenize things and use this in a way to have large language models and generative AI, right? So, example is the health information exchanges. So this was a great, thing that started. I'm told that it related to Katrina and when we had a huge hurricane in southern Louisiana, obviously, that wiped out a lot of healthcare records. We didn't know anything about some of our patients. And for different reasons that all make sense, the thought was, how can we make sure that there is, healthcare data available that's not in a paper form? And then this concept of exchanges came out. But then the problem is the exchanges health information exchanges are dependent on the state of what kind of quality your system they have, right? So there's just that one technical element. Okay, do the health information exchanges have 100% of the information? Is it cataloging it correctly? And then do I have, a vendor or a piece of technology that can harmonize and normalize this data to then have this kind of fertile stuff that I can prop up either my point solution or platform? So there's that aspect. But then there's this whole other aspect that, okay, let's just say we're in the same state. Let's say the exchange system's good, or TEFCA, is another strategy trying to make this stuff cleaner so that we can use it properly. But even just the access to the data now is a problem because some require these kind of direct integrations. There are plenty of systems, and where I live and my wife and I practice, Baton Rouge, Louisiana, where the systems don't communicate to each other. So you can even have Epic in two different places and they don't talk. Like, I can't necessarily see what's happening in the other place. I could maybe opt in for care everywhere, but then that looks a little different because they may be PDFs and that's now unstructured data, right? So it's not tabulated or discrete. So there's just so many areas where this kind of normalization and harmonization of data to just then start what we're talking about, like the things that we're getting excited about, that can only start and happen when you have all of this, clean and communicating to each other. And then to your point, there's this whole other issue that is good or bad when it comes to regional stuff. And where was this, AI solution, trained? What was the data that it was trained on? Is it generalizable? Is it overfit? Is it underfit? And one example, I was speaking at a mental health AI and cancer summit, and I was talking about how, people in the same situation or with the same angst or depression about a certain diagnosis may need to hear things differently, obviously. Like, some need to hear very positively. Some need to hear it's okay to give yourself a little, grace. So they may need to hear different things. Well, that depends also culturally, because I can guarantee you Southern Louisiana people are probably quite different than New York people. So I don't want a New York solution necessarily in Southern Louisiana. So some of it's a good problem, some of it's a bad problem, but the biggest problem is to figure out which one makes sense and which one doesn't. And especially when there's no script, because again, the mind doesn't know what the eyes haven't seen. And this is kind of new for all of us.
It totally is. And I think it brings up such an important point about when you start talking about models, right? So this conversation that's happening in AI healthcare right now, particularly from the LLM standpoint and these generative AI tools, they're all relatively new. So naturally, their track record is much thinner. And folks like yourselves, you're dealing with sophisticated oncology systems that have run forms of AI for years, right? You've had imaging models that have been reading scans. You've had pathology models that have been grading slides, risk stratification, treatment planning, optimization. I mean, you name it. And these tools have all got FDA clearance, peer-reviewed outcome data, and years of clinical validation behind them. But enter in the ChatGPT era, right, with Claude and Grok and all these other things. And you've got AI that's actually now coming in and having an impact on oncology today. So what do you wish that more oncologists actually understood about that dynamic relative to the data and just anything else that you're sort of experiencing in your current remit?
Yeah, I think you nailed it. The first thing that still, somehow surprises people is that we've been using AI for a very long time, as you said, when it comes to machine learning and a lot of the, some of the algorithms that we use for end-stage renal failure risk and several things. We've been using data, and then it's been validated and able to be acted upon. That's number one. Number two, it seems that there is an awareness of, confabulation or hallucinations, etc. But I worry that it's sometimes too polar or binary rather for some clinicians. Like it can happen, and therefore, until it doesn't happen, there's nothing to really consider right now. And I think that level of thinking I worry that it may delay what could still be better than the status quo. So like that's the biggest thing at hand is what is the statistical, percentage of time that we're doing right by patients in a certain circumstance. One of those examples is, screening for lung cancer. So it's like a lot of screening modalities when it comes to colonoscopies and mammograms and arguably pap smears are well, 70%, 80% ish. But then lung cancer screening is below 20%. And we're talking something that saves like has overall survival data. And it's been around for years and years and years and years and years. So if you're using generative AI to be able to flag, hey, this person is, just by the book, the one that benefits from having an annual CT scan, but say, it's only catching that 85% of the time, it's still an error 15% of the time, be it a false negative or false positive. But the status quo or the baseline right now is that we're only, referring 15% of the population. So that's where you it takes this judgment call of like, is perfection the enemy of good, as some say. So I think that's just really important is think about the status quo, number one. And number two is just to recognize that when it comes to AI tools, a lot of this is an iterative process. So it truly takes conditioning and then reiterating and reiterating to reach higher levels of success. Not these, at least the open models, or at least things that have any kind of learning or feedback loops outside of something that's just purely closed. A lot of these require patience and feedback and monitoring, and you kind of develop them over time. They're not out of the box. They're not software in the sense that it's the CD and it is what it is and it's going to work how it works. And I think that's, an important thing to understand, because if we just delay that whole process of reiterating or considering or playing in the sandbox, as some say, then I worry we're delaying potential benefit to patients.
It's such a key point. I mean, because, what you're basically saying there is this whole notion of the promise of AI is absolutely real, but the liability questions are also a key point, right? And I'm really interested in your perspective on agentic AI, because we feel that that's moving, at least sort of in the spheres that we're in, faster than anything we're seeing in health tech. But in your view, where does agentic AI actually belong, both in that clinical and that administrative workflow today? And how do you think the human needs to stay in the loop? Will that always be the case? What's your perspective?
Oh, that's a tough question. I think number one, again, tech and medicine are both humbling spaces, especially when it comes to what we've been able to do in AI today. I think everyone can agree that it seems that error is reduced when you have an agentic workflow, meaning you have specific detailed tasks that this agentic workspace puts together, right? So instead of having these like OpenSea, high level of data systems where you just hope that it gets it right and retrieves what it needs to retrieve, you do this handoff of tasks. So you might have one that is able to look at the guidelines, another that looks at, specifically the molecular data in the patient's chart, et cetera. So we know or believe that is the way to reduce error and have improved accuracy. So I don't think agents are going away for sure. I think they are showing promise, especially on the administrative side, as you were stating, when it comes to, and insurance companies beat clinicians on this. Like they've been using these agentic workflows for prior authorizations and appropriateness on that same exact, concept. Like, what am I being told? What does the note say? Let me extract it. Let me compare it to what I have here, and let me, shoot off a rejection or not. And those do not have human in the loops, I'm told, depending on the insurance company, because for them, the consequence would be us then calling and then kind of working it out, and hopefully the right thing comes to be at the end of the discussion. I think when it comes to clinical decision making gaps or flagging someone or identifying someone for potentially a certain test or treatment, I do think we need human in the loops, not just because of the consequence. Like, somebody might say, "Oh, wow, I have this mutation that can really give me a better survival compared to if I didn't have that mutation with this cancer." The problem is too, though, the psychology of it, because now you might have caused false excitement for a patient, false excitement for their family members, and then kind of pulled it back and said, never mind, we have to do standard chemo. Targeted therapy isn't an option. So there's consequences even outside of medical error that are psychological in cancer that I think we have to be very sensitive to. Am I optimistic that maybe HIT, humans in the loops, aren't necessary as much in the future? Yes, I hope there is a day when automation is that good, because there is a very clear deficiency in cancer that no one has an answer to. You can't make a new oncologist without 14 years of training. All the staff members and people involved. There is a growing gap that we know, because in 2030 we're going to have this like doubling of cancer patients without the same increase in staffing. So there has to be something. So the hope is, that there's automation in certain points or places, because otherwise there is no solution.
Completely. And I love the fact that you said, both healthcare and IT or health tech are very humbling professions. One thing I wanted to ask you before we dive into like the staffing workload and that sort of burden is, talking about this pilot sort of purgatory, right? We've got a lot of folks, especially in the healthcare space, lots of startups, lots of folks that are good at running a bunch of pilots, but very few are actually good at getting to that next step. Now, you've actually navigated this, right? And you've done it successfully. I think you've actually went ahead and sold your company. So terrific. I think that's all great. But as a founder and as a person running also the clinical AI operations, what really has to be true to make that transition from this, hey, promise to the actual operational infrastructure? What's the most difficult part of that transition that never really gets discussed?
Honestly, and this is just my opinion, I think one of the biggest bottlenecks is just having the bandwidth on both parts, the vendor or the service or the tech company, as well as the end user, having the bandwidth to be able to discuss enough and frequently enough the different steps and processes to make this a more scalable solution. So the thing that hinges for a pilot, I think, is like having your champion, like at the clinical setting, if it's a clinical tool, or at the institution, having that champion that can ensure that all of the different factors, again, interdisciplinary, but this time in a tech way, your IT person, your informaticist, your innovation officer, the informatics team on the vendor or health tech side, having a steadfast engineering team to be able to adapt and to fix problems and find solutions in a quick amount of time so that clinicians don't get frustrated. You have to have all of this in place. And that's the purpose of a pilot, is how much can I do and how much tinkering and tightening and loosening and, waiting and all of this other stuff to be able to make this as semi-autonomous as possible and as reliable as possible. And unfortunately, at least as it relates to healthcare and cancer care, there just isn't a lot of bandwidth like that, like especially when you talk about now community settings or places that are feeding, rural populations, etc. So I think the success lives and dies by the amount of involvement in that pilot. And I think pilots fail when there isn't enough communication back and forth. And it's more just a tryout and a feel. And I'm like, dissatisfied customer, I'm going to return the thing, like as if it's a pair of shoes. So like that, it's very different in that manner. It takes also resources in the way of finances, because you might need an FTE, a full-time employee for this purpose. And again, just a lot of beta testing. And I think that's why I think it's a resource deficiency to be able to then make it scalable and have everything done right at a robust enough level to be able to scale it just because of the resources.
So what should a healthcare system be asking before they turn agents loose in this particular, in sort of your perspective there? So you go from pilot, then you start to scale. You were talking about the agentic thing. What should they be thinking about that? And I'm also curious around governance, right? Because there should be questions that are in place ahead of the pilot. How do you think about that? And how do you think about that driving what agents they do deploy in practicality?
Oh boy. Yeah. I mean, this one's huge. And I've noticed, it actually even varies kind of quite considerably just depending on not just the region you're at or the size of the institution you're at or the number of systems, but even just like personality or just the flavor of the person you're working with. But you really want to have a very steadfast idea of what does the governance and monitoring plan look like before you prop up the agentic workflow. If you have this mentality that I'm going to prop up these tools, models, or agents, and then we're going to, be iterative and back and forth and figure it out as we go. That is a lot of times the experts I've talked to, especially at larger health centers, that's where things fail. You need to have all of that identified beforehand. Who is the person that this first goes into the hands of? Who is the person on your side that's actually auditing and taking X percentage of these things to ensure accuracy? Who's the person on the health tech side or the vendor side that's going to be auditing? What is the frequency of audit? And then that first, point of contact, what are the different pathways they escalate to? Who's the point person with the IT team that's going to be able to be flagged? Are they going to be available? Who's the person that tells in the clinician or the clinic team, hey, we need to pause all of this because it's starting to either drift or be erroneous because we found that it's mistaking this one term that we use here that apparently no one else uses it with their vernacular elsewhere. Whatever those triggers are, you have to have that entire process mapped out beforehand. And I'm told that is especially the only way that something succeeds. That doesn't mean everything succeeds, but these are the questions that has to be addressed. That have to be addressed by the team at the institution that the health tech team cannot give you. And now once you've identified those things, and you can build those things even with the health tech team, where you could say, how often do I have to audit? What do I need to audit? Where's my data coming from? The second piece that I worry about is dependability, because now a lot of these solutions sometimes have multiple chains in the link, so to speak, or links in the chain. So you have, potentially if it's an HIE solution, you have a vendor that's just cleansing the health information exchange data. And then you have someone, or if it's a Fire connection, that's delivering it, based on, a certain cloud of storage that is the cloud the same at the institution as it is at the vendor. There's just so many different places that these things could go awry. Having all of those identified and ensuring that there's a solution should this have to be paused is also very important, because otherwise it could be catastrophic.
So really your advice here is, ask those difficult questions up front, really focus on things like the accountability, the escalation, failure, risk, any of those things. And I guess that's sort of the advice we heard, which is, measure twice, cut once kind of thing, right?
Yes, so, exactly.
Yeah. Yeah. But underneath it all, I think what you were also sort of alluding to is this notion of sort of a staffing crisis that is sort of happening under every conversation that we speak about with respect to AI, and just in specialty care in particular. We're seeing things like our wound care nurses, right, that are just covering caseloads that they were never trained for, as an example. We've got physical therapists that are spending every lunch hour or pajama time taking, documentation home. These are not marginal roles, right? Their interventions actually prevent hospitalizations, but they're burning out and they're being overlooked. And you were talking earlier about AI as sort of a workforce solution. When you think about it that way, do you actually think it's something that keeps skilled clinicians in the profession? And what is the opportunity that isn't getting enough attention when you're advising other folks on what, sort of use case is going to deliver the first relief for these workers?
Yeah, I mean, at least for the short to mid, maybe even long-term future, but let's just say at least short, there's just so much stuff that is not at the top of license. That's the biggest problem that I think is most immediately solvable. When it comes to this, wound care team, or it comes to the clinician or whoever these different parts of the team that you mentioned, whoever they are, there is so much time going into coordination and just communication of handoff and retrieval of certain pieces of information, or scheduling, or cancellations, or making sure the data is there, or the past history, which is always relevant for wound care, or the antibiotic history. So much of this that is below the level of specialization for that specific person you're talking about, that is immediately and abundantly available to be addressed. So that to me is really where we need to be honing on, because maybe in some future great problem to have, things are so good that we don't need that top of license specialization. I just don't see that like anytime soon, because there's just so much to be had before then. So, I think the argument on the other side is a little bit more concerning, which is, are clinicians or are any specialists of the healthcare provider team, as the labor of a lot of these administrative and more rote things, as they're taken care of, does that mean we're just gonna have to see more patients? And I think that's an ethical question, which is just like, there are more patients that need to be seen. You can't make an oncologist except 14 years. So we're just gonna have to figure that out as humanity. I think that is maybe a more of an immediate-ish concern that is realistic as far as an oncologist, just the numbers that you're able to now have, which again, in a weird way, is kind of a good problem to have, rather than not needing us at all. And I think just ASCO this past month really showed that. I was participating and moderating a bunch of specialty panels for lung cancer and hemonc, malignant heme cancer and all this stuff. And the complexity of this data and debates between the leading specialists in the country, I think just really underscored, I made a post about it, like how that's not going anywhere. I mean, you can't make an agentic workflow when even the top specialists of understand things today to these complicated diseases have different experiences and observations and opinions. So for that reason, I think we'll be able to practice at top of license much better and more purely, which I do hope will help fulfillment and reduce burnout.
Yeah, it's, again, it's a very human dynamic, right? It's interesting that we are using technology to help us get more human, and sort of staying on that thread. This whole notion, specifically in your field, you've spent years really building trust, right? Whether it's with the cancer patients, as you mentioned earlier, who are just scared, or families who don't really fully understand or absorb, what they're being told, or clinicians that are just being burned out by the technology, right? That whole confidence factor that you were talking about earlier has really dropped, right? It was sort of 70% in 2020. Now it's down to 40% confidence in about 2025. I mean, that's big. Those are big drops, right? And our clients are telling us that clinicians are really skeptical about another tech solution. And we say that specifically in our space because we play a lot with sort of the EHRs. And we know the EHR really has had some impact on the confidence within the healthcare space. So what's the whole difference that sort of has to happen now for clinicians to actually start to trust this technology and trust the governance, so that it actually starts to become a solution to contribute, like, as you mentioned earlier?
Yeah, I think, and this is purely just my opinion, but I worry that there's just been so many point solutions, and by point solutions, I mean something that just has a very specific honed in solution. And then you have like a dozen, different variations of this point solution, and some are better than others and some are not better than others. And then having an experience with just one, say it was, too many points of potential failure and it was breached and there was no plan. Now it's going to make you really have kind of guarded excitement about that specific point solution in general. If the prior auth thing was terrible, and nothing was actually getting authorized, or the bed scheduling, was canceling appointments when it shouldn't. I mean, pick your example. I think my opinion part of that I disclaimed was, I think this whole concept of platforms and the integrity of a platform is going to be really key and essential. And there are platforms that can take care of or hedge a lot of those problems that are amenable to multiple vendors and point solutions. And I think a focus on that platform aspect is the hedge against potential investment, disappointment, and failure, because the integrity of that can help coordinate and be the be the interstitial, process or network by which the success of these more focal points of solution can live and be viable.
Yeah, it's a fascinating topic, and I think it's one that we have a lot of work to still do to earn that trust, right? So, but super exciting times, and definitely interesting to see what happens. And actually, that brings me to a good challenge question. Do you think 2026 is really a bubble or a correction? We've read a lot of stuff in the news, right? We're hearing analysts talking about 2026 as sort of this mass extinction event for AI healthcare startups. Essentially, this moment when that promise to prove sort of really exposes lots of fragile economics underneath. And it starts to also debate about a lot around what actually gets funded. And we're seeing a lot of AI healthcare companies that are going public on a promise, but sometimes the proof is still being assembled, right? So, and some say, hey, this is going to be more of a correction because until the outcomes data is really real, it's not really something that we can bank on. Now, you've watched this from inside a company that's had to make that exact transition. So, in your view, what do you see actually separates the companies from those that survive and will continue to survive past 2026 and those that are just, hey, it's a bad bet and may not survive the next 18 months? And the point I really want to understand is for vendors that are considering AI, specialists or people that, technology companies, what should they be demanding from those vendors that may not survive the next 18 months?
Oh, yeah. I mean, if I may, I'm going to say it's kind of both. Like there is an extinction that is happening sadly. And I say sadly because I've met many good intentioned people and CEOs and founders of amazing, solutions that just have put everything in. And I mean, resource wise and heart wise. I think the reason they're failing is there is a resource exhaustion because I don't know that overnight there's going to be this disappearance of where you don't need upfront resources that eventually, may make the ROI net positive, at least for the vendor, and hopefully definitely for the institution, if nothing else, just in the quality of patients' lives. My point in saying all that is, and part of what my newer startup, Tensor Black is trying to do is how do we bring people, all of us, you, this podcast, how do we bring those good meaning people together and finding opportunities of collaboration and I don't want to call it M&A, but really not trying to invent everything on their own. There are a lot of people that are doing amazing things that are all different pieces and parts of this entire, transformation that could be. And you're starting to see that now. So you've seen the companies that have failed, but you're starting to see companies come together a little quicker. And on the flip side, I do see companies saying, "Oh, well, we can build that," or "We have a fantastic, group of engineers, and we can do that." But then the time lost in building it and doing that entire validation process and auditing process and stuff could be the Achilles heel that kind of prevented this solution from being viable and scalable in another aspect. If somebody's already done that, I think there needs to be an openness for the chance at viability compared to any other place or point in the history of either health tech or just even capitalistic kind of pursuit, right? Like a SaaS system is very different and may not make sense or need to have people come together and acquire because the SaaS is a SaaS. But there's so many different elements to these solutions, these platforms, and to enriching and harmonizing the data, complex data at that when it comes to medicine, that collaborative efforts need to be almost like a section of the company is what I would say. Like just have somebody looking to see who's doing similar stuff and where does it make sense to do this together to kind of aggregate the resources, delay the potential exhaustion of those resources, and that at a point where the solution can be demonstrated before that happens.
Yeah, it's a fascinating journey, and I'm really excited about what's going to happen next. I am going to ask you our question later today, what your vision for 2030 is. So I'll park that so that you have a little bit of time to think about it. But in the meantime, one thing that is really fascinating me, and we're seeing a lot of headlines in the news, right, about like the next generation, how are they handling AI, no future jobs, and especially as a mother of two young adults, I think a lot about what this means. You've got healthcare systems and you've got your clinicians that have been trained before ambient scribes existed, and they really built their diagnostic instincts and skills under pressure. But this next generation is going to train with AI right from day one, and they may not have the full practical experience and know when to be able to push back on AI and trust it, or when to say, hey, this doesn't feel right. I've seen more of this in my own experience. So what does de-skilling risk actually look like in practice? And is it as serious as some of your podcasts have actually suggested? And what do you recommend for the next generations of clinicians as they're thinking about, leveraging AI under these types of circumstances?
You bring up a great question that I think, I should disclaim that I studied philosophy in undergrad, so I might be a little more radical than others on this opinion. But I have a 10-year-old son, and I was telling him that he needs to do a project to us, like, it wasn't really punishment, but like he's going to present to our family about why vegetables are healthy. Like, why do we need vegetables, right? And he's like, okay, well, give me your laptop. And I gave him the laptop, and this is the first time he's putting together a PowerPoint. And I just immediately had the debate because I was going to try to explain to him, Google and how you have to kind of authenticate or vet the source that you're looking at. Like, is it like actual literature, or is it just an article on literature? Trying to give my 10-year-old these concepts. And then immediately
I was like,
video,
right?
Exactly.
Or a TikTok video.
Exactly. It could be anything. And then I was like, but then, there's this whole aspect of experience that like you can't be taught. So like, how is my 10-year-old going to know what that vetting process looks like when he's actually like exploring the internet for the first time other than YouTube? And then I was like, or we could just ask ChatGPT. And I'll tell you, we ended up going with the ChatGPT route, right? And then, he got good at, verbal pilling, which is like just start, asking out loud because he can't type well. And he had this great discussion. So in one aspect, he did really sharpen a skill that a lot of adults, don't have, which is verbal pilling or voice pilling AI, where you're not doing less typing and actually having this conversational process to be able to come to a conclusion. It's very effective, I'm told, even for coders and engineers. But what he didn't do was that grind, that, cholinergic, dopaminergic process that behaviorally has been shown to teach, especially someone like a physician, where you have to be very fastidious and go really deep just to be able to get a minimal amount of reward. Sometimes just one answer, like you'll have to study for an hour or two. If that goes away, my bigger concern is really just the hardiness and the durability of individuals in the future to be able to have, the patience, the wherewithal, the length of frustration and failure that it requires to be able to come to a conclusion. Now, the counter argument could be, well, we're not going to live in a world where that's even an issue. But I need to remind people, even with all of this stuff that's been happening, as it relates to worldwide, tensions and wars, there is a lot of bottlenecks that can occur to make this stuff go away, including access to minerals and key elements that are required by these AI systems and these GPUs and everything. I had somebody on my podcast where they were a legal AI person, and they just outlined so many bottlenecks of why something could get on pause, like even a potential frontier model if it related to geopolitical tension. And so what happens then if that retrieval process was to pause? Do we have the durability, fastidiousness, and that kind of learned training of difficulty of not getting A to B, but rather A to Y to get the same answer? That's my big, big concern. And I do not have an answer to that other than I still try and make my kids, unlike the example I just gave, because that calls me out, to try to just have them used to this level of failure to reward ratio. But it's a serious concern that does truly worry me.
Yeah, it's a fascinating social experiment. And I almost, to some extent, wish I could parachute, 50 years into the future to sort of see what's going to happen and then come back. But we'll just have to continue to wait and see. But you brought up something fascinating when you referenced the ChatGPT. So I can't resist asking you this, because as the OncDoc, you really talk and establish yourself as a fascinating and credible voice for patients, right? Navigating this whole landscape of potential bad information. And you mentioned ChatGPT. Now, I know I've done this myself with my daughter. She had a scare. And what I did is also used all the AI models, right? ChatGPT, Claude, etc., to try to run clinical notes through that. And I think your medical doctors are doing the same to some extent. But what does that do when you start to think about your role fighting health misinformation? What worries you most about sort of AI spreading some of that, right? And what does this whole notion of clinical grade AI need to include to reduce that?
Yeah, it's an important question, and just on the spot, I hope that there's almost these profiles of these frontier LLMs that are similar to what I've prompted mine to be. Like, in my default setting, and I just say you need to only go to literature sources, cite every single one where you make any statement on a dosage, on an indication, on a guideline, reference the guideline. You need to double check your answers, and then I'll basically take all that, and I have my own agentic workflow that then just cross challenges everything that was said through a different frontier LLM. So that thing that I built, I know most people haven't, but I don't think we're far away at all to be able to just opting in. I want the physician version of this. That's kind of doing a similar thing. But to your point, until that day comes, there is a plethora of information. I mean, we know how much Reddit is used by these frontier LLMs and these other sources that could just like very matter of fact, put it in front of you and perpetuate these kind of misunderstandings. And I think, unfortunately, you just need to have this discernment that only comes with experience. Like I said, my 10-year-old didn't have. Like, how could he be discerning if he doesn't have the experience to be able to know what does or doesn't sound right? So that's why I also think specialist and this human type of license thing is not going anywhere. Like, it just can't be. I do think, rather than maybe a human in the loop, there could be this almost like, specialty guild that one day sits in front of the stuff that's coming out to be able to vet it from a medical aspect because of those 14 years of training or whatever, and potentially in mass volume. I don't know. Or you have these agents that are reflective of that individual, and then now you're pooling them together so that you can actually scale them. But I don't think human in the loop is going anywhere. And I think it's necessary, even because of the unknown and the unknowing on how we're going to receive these things. Because one of the biggest paradoxes that I kind of live in when it comes to tech and AI and medical solutions is how much of a lack there is of medical and health professionals with these tech companies. Like, I will ask them, like, oh, you have an oncology solution. Like, who's your CMO? How many oncologists do you have in your team? With, like, we don't have any. I'm like, well, then how in the world, respectfully, like, and it's not, bad meaning. It's just like the mind doesn't know what the eyes haven't seen. They're not aware of all of the, but this, all of these different nuances that can be in place. That sometimes I've seen like anxiety over the founder's face. It has to take collaboration. I think all of this keeps going back to collaboration with a capital C in every single aspect, right? When you're propping up a solution, when you're building a solution, when you're vetting a solution, when you're using a third party one, I think this collaborative process is going to be so key. And I think we're going to mess up, unfortunately, before we actually figure out all the places that this is necessary in.
Yeah, thank you. I love your solution of the governing boards, the humans in front of the agents, so to speak, or agents, or the governing agents of agents with humans. There's so much that can come out of that. Clearly, it's an area of focus that we definitely need to continue to watch. And it sort of brings me to the challenging question for the podcast today. We've spent a lot of time talking about sort of ripping things apart, right? Like where AI actually fits, where it doesn't, where we're talking about it getting oversold, where it's paying the price, where it's really sort of helping and supporting. And I promised you I was going to ask you this. So when you look out to 2030, what does success look like, and what would make you say, hey, in healthcare, we got AI right?
If I may answer for oncology specifically, the thing that I was hit the hardest with in practice is when failures happen. And I mean failures despite doing everything right by the guidelines, right? So, there's this thing called EGFR. It's a mutation in lung cancer. And it's very favorable in the sense of, if you have stage 4 lung cancers, this qualifies you to get a pill to where you don't need chemotherapy. And it can have, years of control where you don't even see any disease. And I would just like, the first 3 or 4 that I had, the patients, even if they were rural or completely medically non-educated, would have tears of joy just because they could see how excited I was, like about like, this is so great, da da da. I'm so happy. This changes everything. And then I had my first time that I had to walk in there, and after 6 weeks, this patient blew through and progressed. And I was so embarrassed, right? And discouraged, and even like felt somehow it was my fault because I was excited. Well, I can tell you, I've never had the excitement again, even though it happens infrequently, 1 to 2 times out of 10 patients, right? But I've lost the enthusiasm forever because I don't ever want to, experience. And I got to experience one time what it's like to get excited about something and be wrong. So when you look at studies, you see these, like, you see where they, fall on these plot graphs. Okay, it's better than survival. It's great. Wow, look, it's all the way to the right. But you see these tails that can be very variable on like the people that actually fell below that and above that. I think in 2030, all those tails of all these studies are going to be so tight. And they're going to be tight because we're finally able to consider so many different variables we know are part of the cancer treatment process that we just cannot consider. Like your polymorphisms or your germline inherited stuff that you were given, like the way you metabolize drugs. I'm Indian. I'm going to be different than a white male because a lot of the stuff, for anesthesia may have been studied on white males. All of these things that we know matter, medication influence, and even, apparently how much you can taste bitterness has to do with your innate immunity. And people that can taste bitterness really sensitively have much more robust innate immune health, so they don't get viremic from viruses like COVID and flu nearly as much. This is validated in NEGM. So you have all of these factors. In 2030, you're going to have, I wish we didn't use the term precision medicine already, because this kind of precision and personalized medicine is so different than anything we've ever conceptualized. If you want to get techie about it, I think we're going to have stuff that's very tokenized about us. I think they're going to be, these almost like not an actual thumbnail you plug in, but just tokenized information that's fluid and everyone can analyze, and you could put in your different AI solutions and point solutions and platforms and immediately extract things with high fidelity and applicability to where you don't have this record deficiency or this data deficiency to even be able to make your decisions on time. I think that will go away. And I worry, let me put it this way. Well, you said everything that's right. I think those are all the things that will be right. And I think there's going to be probably 2 to 3 elements that we can't even conceive today, that we couldn't have even conceived. And I think the way to make sense of that is look at what people have done with these videos of AI, right? When they showed it 2 or 3 years ago, people eating spaghetti, this and that, it was like so obviously AI. And now it is unbelievable what, was classically called deep fake. And now it's just like AI stuff. If you could do that, I don't think anyone 2 years ago would have thought we could have done it this well today. That's, nano banana, all the stuff that they're able to achieve. Imagine what that looks like when it comes to potential molecular targets and protein targets and protein, conformations for antibody drug conjugate delivery. I'm saying all this complicated, terminology, but my point is a lot of it is taken individuals studying for weeks at 10 hours a day in a lab. The computational power you have and the mass amount of what can be is going to be accelerated in a way that we've never been able to not only see, but can't even conceive.
Dr. Juneja, what a conversation. I know I came in with a ton of questions, and I know our audience did too, and yet we're leaving with all the answers that we didn't have an hour ago. Thank you so much for your time. And on that note, I know you're really a busy man, so I'm going to let you jump while we pull in our top takeaways. Thanks again. Hope to chat to you soon. All right, recap time. Here are the things that really stuck out for me from this conversation that we just had with Dr. Juneja today. The first point is the hardest problem in healthcare AI is that translation between what the technology can do and what a clinician can actually use at the bedside. Most implementations really stall in that gap, and closing it takes builders who understand clinical workflow as deeply as the model. Dr. Juneja's whole career is proof that translation work is the actual work. It was also really interesting to hear about data quality as being the foundation for everything else that AI sits on. Models that are trained too narrowly on institution-specific patient populations produce AI that might perform well for those patients that are already in the systems, but it quietly fails for everybody else. Specialty providers and the vendors who serve them have got to integrate that foundation into anything before they build anything else on top of it. And the honest measure of healthcare AI is really whether it does give clinicians back the capacity to be present with patients. Done well, it returns time, attention, and judgment to the people who trained to provide that care. But done poorly, the consequences are that it adds another layer between the clinician and the person that's sitting in front of them. And that is the version that we have to collectively refuse to ship. And that is a wrap of what has been yet another great episode of Humanify AI Health Tech. As always, I'd like to thank you, our listeners, for tuning in. And if you're joining us on Spotify or YouTube, we'd love to hear your thoughts in the comments. And don't forget to leave us a rating while you're there. Once again, I'm Francesca Vereb, Head of Marketing at NetHealth, and I'll see you next time.